Welcome to the Plastic Fantastic podcast, brought to you by Mr. Adrian Richards and myself, Alison Telfer. Adrian and I go back many years having worked in this industry. Adrian specialising in all things to do with cosmetic, plastic and breast surgery, and myself all things to do with cosmetic, non-surgical treatments. We're going on a journey through this podcast. I think I'm secretly trying to find out who to get my best facelift from. And Adrian, who knows? But we're going on a journey to speak and interview and interrogate the most fantastic practitioners, doctors, dentists, nurses and business people, all those who've been touched by our industry. We hope you enjoy the show.
So today, Alison and I are joined by Sach Mohan over the Revere Clinics, who is next to us on Harley Street, very well known in the aesthetics industry. And we're going to be talking, what are we going to be talking about, Al?
We're going to be talking about all sorts of things. I'm delighted to have Sach. I haven't seen you for a while, Sach, but we go back a long time and we've had a lot of fun in this industry, I think. We're going to be talking about your really horrible experience recently with COVID. We're going to talk about your phenomenal success with Revere, and you're going to give us a bit of an insight into your Indian patient group that a lot of us don't treat. Anyway, welcome, Sach. It's lovely to see you well again.
Well, thank you, Adrian. Thank you, Al. I'm very, very glad to be here. You think to yourself that during this lockdown, we sit here with twiddling our thumbs, but no, we're all very, very busy and getting prepared now. We're getting prepared to get back into the clinic. So it's nice to get a little bit of respite and get a chin wag with you guys.
Yeah, and Sach, we were really. I was up late one night, and I just happened to come across your story on Instagram. You talking to Dr. Desai. And
Sabrina,
and I was about to go to bed, but I stayed up for 45 minutes watching it because it was I thought it was so riveting and interesting, so from the heart. So could you talk to us a little bit about what happened to you?
Yes, I think it all started in the beginning of March. It was a casual dinner with a fellow colleague of mine who works in A&E. And just having dinner, my family was around, and lo and behold, by mid-March, I woke up on the 13th of March with a fever, and the first thing that went through my head is, oh my God, I was at a school parents event the night before, and I've got COVID, and I've infected 200 other people as well. Like most people that contract COVID, it was fever. It was muscle pains and it was tiredness, and the fever, it was pretty high. It was going up to the high. It was approaching 39.5, and no matter how much paracetamol I was taking, I just couldn't get on top of it. And the lethargy that comes with it was horrible. So it's been a very, very, very long time since I was bedbound, and I was bedbound, and this continued for 9 days, and it was I think the 22nd when I woke up, thinking that one of my boys was sitting on top of my chest. I opened my eyes, there was no one there, and it was at that moment, as I mentioned earlier, that I had a little pulse oximeter by my bedside, and I popped that on, and my saturations had dropped significantly, and it was at 79 odd %. And I think that was the cue for my wife to call the ambulance. Odd experience, with the COVID.
Sach, could I just ask you a couple of questions? So the fever, I mean, what does the fever feel like? Do you feel hot, and how do you feel?
You go through the cycles of feeling really hot. You don't really know what to do with yourself. Because when the fever kicks in, you get the shivers as well. So you have this tendency where you really are hot. Your medical brain is telling you to throw the duvet off, but you're feeling cold as well with the shivers, and you want to pull the duvet back on again. So
yeah.
And were your family well at this time? Your family were well?
They, despite my self-isolation and trying to stay in one room, they contracted it by, I think, day 4, day 5, into my fever. Right. So thankfully their symptoms were far less severe than mine. The kids got through theirs and came out the other end in 3 odd days. My wife her symptoms lasted 8 days. But I wasn't around to see much of that because, as I said, day 10, escorted out into the driveway by the ambulance crew. They do the whole workup in the ambulance, it wasn't wasn't a difficult decision for them to whisk me off.
So, a little question. So, the normal PO2 readings should be what, 98, 99?
Mm-hmm.
Yeah. So yours really had dipped quite low. Would you recommend that people out there do get pulse oximeters, Sash?
Oh, I really would. We keep it in the household because I like to measure, as part of our fitness regime. The kids are into sport, so for them it's a rough indicator of baseline fitness. Having a lower resting heart rate is really good for you. And then in the event of illness, it's also a great barometer for measuring how well your breathing is. And this came in really useful for me because it was my trigger to ensure that I called the NHS when I really, really needed to.
Yeah. So you knew it was your saturations were going down, and then they took you in the ambulance. What did they do in the ambulance, Sash?
Drive very quickly. I was popped on oxygen, and it was it's only a 3-mile drive to Watford General, and there A&E, then straight into resus, and then all the lines started going in, and the blood gases, and blood gases were done. Chest X-ray showed this heavy consolidation, indicative of a viral pneumonia, the cytokine storm, as they say. And after that, within 3 to 4 hours, I wasn't getting any better. I was actually deteriorating and ended up on ITU, where I spent a further 4 days.
Yeah.
And were you very aware of all of this, of what was happening? What was your fever doing at this point? Was it the same?
What was my, sorry?
Your fever doing at this point? Were you very aware? Were you sort of a bit out of it?
I was extremely lucid because, if you can imagine, as an alpha male control freak, when a junior registrar comes in wanting to put an arterial line into you, of course you're going to supervise him as much as you can without getting him too nervous. So yes, I was very lucid because number one, it was fear. For the first time in my life, I was actually scared because of the nature of COVID, and the fact that I was taken away from the family. I was on my own. There was no way that I was going to see the family again, unless I made it through the other end.
Yeah, and they obviously can't come and see you, or And how was it actually in the ITU? Do you aware of what else was going on in the ITU?
Yes, the Watford General setup at that time was that they had converted the elective theatres into ITUs. So they'd increased their capacity, waiting for this surge of admissions. I was in the ITU area, which is quite open plan, and I had somebody in the senior management of the hospital executive team in the bay next to me, and a 24-year-old girl on the other side. So it was then when it really dawned on me that, look, this is this can affect anyone.
Yeah.
And these were people that had no comorbidities like myself.
Yeah, because you're pretty fit and healthy, and yeah. So it's interesting, Al. You mentioned that your husband has had it, Al.
Yeah, he had, and I think it's a funny one because I think there's certain parts of it that are consistently reported and almost predictable. So, like you, Sash, my husband had the lethargy, the exhaustion, that to begin with, and then he thought he might be getting better, and then all of a sudden he sort of fell off the cliff, so to speak. But he didn't need to go into the NHS, but he was at home and he was really ill, and it took him several weeks afterwards to recover. And I think that must be the scary bit, is the unpredictability of it. Because if I think about, say, you sort of came out the other side of this, but then you've got Kate Garraway's husband, who's still in intensive care and has been for several months. What's the difference, do you think? I don't have much of an understanding on it. What's the difference actually between how you managed to come out of it and some people don't seem to be doing so well?
If you can imagine, I've become a walking, talking encyclopedia on COVID after my own experiences in the search of answering the question, why me? Why was it me? and hearing reports now, even patients and patients that have had a bout of COVID, who may not have even had chest symptoms at the time, doctors are now reporting that they are walking around with pulmonary fibrosis now. So we've got people that have never been admitted, never been in ITU, but now showing chronic changes of fibrosis in their lungs. And that's the scary thing, for us all, in that, the vast majority of the population will contract it if a vaccine's not launched in time. But how much damage will it do to the general population's health?
Yeah. Could you just explain to us, Sash, two things? So number one, what is pulmonary fibrosis? And number two, so you got it and Alison, your husband, got it, but your wife did not get it so bad and your children did not get it so bad. So why is that?
I think if we look at the way that the virus infects, it's essentially, it's spread by droplets. So you're likely to get an infection either through the nasal passages or into the throat. And then as the virus enters the cells, so it affects two types of cells. The cells, I don't want to get too complicated, but essentially the virus has a predisposition for anything that has an ACE2 receptor on it. And we find these ACE2 receptors all over the body, from the lung all the way down to the testes. So you find these everywhere. The other place that the virus likes to attach itself is on the endothelial lining. And the endothelial lining, as you know, is found wherever there is a blood vessel. So we've got nearly 29,000 miles of blood vessels in our body. So that explains, number one, why the lungs are infected, because we have lots of ACE2 receptors sitting on our type 2 alveoli, in our air sacs of the lung. And then we've got 29,000 miles of blood vessels. So when the virus enters any of those cells, it enters and then replicates, damages the cell, and then hordes and hordes of more viral particles are then released, which then go on to infect others, and then that causes a cascade.
And is that the cytokine storm?
So in the lungs, that's called the cytokine storm. So as the virus is released, you then get an inflammatory reaction, and these cytokines are released as part of that inflammatory reaction to then recruit our immune system.
And would you mind just explaining to Alison, because she probably doesn't know what a cytokine is. What is a cytokine?
A cytokine is a molecule that is released that triggers an immune response. So we have different types of immune cells which help our body. You have T lymphocytes, you have macrophages, you have B lymphocytes, you have memory cells. And they are recruited by the release of these signals provided by cytokines.
Cytokines are sort of the messengers.
That's right.
Yeah, okay. Well, thank you. I didn't know that. So thank you very much. So the other question is, why, for both of you, did your family not get it so bad? Why was the man, middle-aged man, if you don't mind me saying, Sash, why were they so much worse?
I find that in my case, my only explanation, I can imagine, after being discharged, I had to have a full workup because I had other organs that were affected, and we can talk about that a little bit later on. But for me, when I had my workup done afterwards, the only thing that was flagging up was my chronic deficiency or insufficiency of vitamin D. And vitamin D has been well documented as an attenuator, meaning it suppresses excessive inflammation in the event of ARDS, which is an acute respiratory distress syndrome, which happens if your viral pneumonia gets worse. So that, I believe, in my case, was the reason that I tipped over, because my body did not know when to stop that excessive inflammation. And that's what caused my cytokine storm to be a lot more. And that's what caused so much more infiltrate to then take hold of my lungs.
And can you remind us quickly about what vitamin D is and where it comes from?
So vitamin D is one of our 4 main fat-soluble vitamins, and alongside A, K, and E. Come on, you're testing me now.
A-D-E-K, ADEC.
ADEC, right. So that's the mnemonic you remembered from med school, I guess. So it's a fat-soluble vitamin. 90% of it is derived from UVB rays hitting our skin and converting a cholesterol in the skin into an active form of vitamin D. And it can be activated in the lungs. It can be activated in the liver and the kidneys, and its storage is predominantly within your liver and your fat.
Do you mind? So I know when I listened to you late into the evening, you were saying that if people are overweight, the vitamin D is stored in fat. So the more fat you've got, the less it's more stored in your fat tissue, the less you've got in your blood.
That's right. So studies have been done suggesting that when obese individuals are supplemented with vitamin D, in order for them to show a significant increase so that they are then at a normal level, it is requiring anything between 3 and 10 times the normal dose as a skinnier individual to achieve the same elevation in levels.
So COVID seems to be worse in people that are slightly heavier, high BMIs, doesn't it?
That's right. So the risk factors for COVID, believe it or not, are also the same risk factors for those that have a low vitamin D. So if you have a low vitamin D, there is an association that you will have a predisposition for peripheral vascular disease, hypertension, and coronary artery disease and atherosclerosis. And that is something which, if we think about it, the mortality rates that we're seeing with COVID-19 are also predominantly in those individuals that have those associated risk factors as well. So I'm not saying that there is a causative relationship, but there is an association.
So you could still get it, but it's much worse if you're low vitamin D. Do you mind us asking what your vitamin D levels were and what they should be?
My vitamin D levels were 7, and it should be over 30.
Oh, wow. So they were, what's that? That's a quarter. Is it a quarter of normal?
It's a quarter of normal. And that then also leads on to why was I deficient in vitamin D? And that all boils down to being skin of color. And that may be an explanation why why the mortality rate amongst the BAME community is twice that of a Caucasian population, is maybe because we do not have enough vitamin D, because we have the inability to synthesize it. The melanin in our skin acts as a block to the UVB, and those of us that for whatever reasons, I'm a second generation Indian, my parents came here in the 60s, or migrant populations that come here, because of the lifestyle in the Western world, and the fact that, we're in the Northern Hemisphere, and the Earth is at a tilt, and when the sun's ray hits the atmosphere, it needs to get through a much thicker layer of ozone, that we're just not getting the UVB exposure to help us synthesize enough vitamin D.
So I went out after I listened to you. I went out and bought. Can you see?
Good, good, good. Can you just check? We need 2 other ingredients in that to help you absorb that. First one is magnesium, and the second one is vitamin K as K2 as well. So despite the nice nice dosage you've got there, you need those other vitamins to help you absorb it.
What else do I need? I need
magnesium and vitamin K2.
I don't think I've got those. I'll just have to get my glasses to check. But, carry on. I'll check in a minute. Yeah. So magnesium. What were they again? Magnesium
and vitamin K.
Is there a supplement you would recommend then?
We can put it up with the blurb associated with this podcast a little bit later on after the show. The ones that I use, I have different types of multivitamins. I can't access them right now.
Yeah, we'll put it in the show notes. But I think certainly worth taking. Al, do you reckon your husband was vitamin D deficient?
I don't know. I mean, he's. I would say I spend, if we're going to talk about symptoms and sunlight and all of that kind of thing, I spend more time inside than he does, because my clinic doesn't have any my treatment room doesn't have any windows in it, and he's outside a lot more. But I don't know how to. He is. Every year he will get the flu. Every year he will get a cold. Every year he is mildly asthmatic. I don't know if that plays a part in it. So he does pick things up, and he's always saying to me, I can't believe it, you're never ill, you should be ill, the amount of alcohol you drink, you should be ill. But then we've realized, what do they clean hospitals with? Alcohol. That's why I'm never ill, you see. But the weird thing is though, I did have 3 days where I could barely move. I attempted to go for a run. I couldn't. I was absolutely on my knees, exhausted. But then that's all I had. But I did have that about 10 days after he sort of had begun to get ill. So I don't know whether I did have something or not.
One thing I think is, so I've had the tests, and like the pregnancy test, and I think you have to have a certain amount of antibodies. Is that Sash? Is that right, to test positive?
That's right. So we have testing is another thing. My house is full of different tests from all over the world, and I've brought them all in. I'm testing them for various health organizations and ministries. And one of the things about testing was why was the UK government and the NHS not testing in significant numbers at the very beginning of this? Why did it take so long for us to firstly consider the target of performing 100,000 tests per day? And what was the reason and rationale behind it? And I can tell you that when I was admitted, the test that was performed on admission, it's not a pleasant one. So it requires a nasopharyngeal swab, and it's not pleasant at all. You have to, in the nose, back of the throat, whatever, and it has to go to the very, very back of the throat. And I had barn door COVID. There was no doubts about it. But yet my admission test came out negative. So and this is the key thing here, is that the false negative rates on those tests are very, very high. So it wasn't actually helping the healthcare professionals, because at the end of the day, they're still going to treat you for the symptoms anyway. And it doesn't really, and they'd lost faith in the tests because so many were coming out negative. If we now look further down the line, we're now seeing so many patients now getting false positives. So they've had the COVID infection, they've come out the other side, they're now asymptomatic, and they're having the test done just to confirm. But then coming out not with a positive antibody test, but they're coming out with a positive test for COVID again. And these are false positive tests because the body is detecting the dead viral particles that are still being eliminated, because that elimination process has a half-life of 3 months. So you will be, for many, many months to come, you'll still be shedding those viral particles. And that's why people are still getting false positive results. And that's what was causing the significant number of, we were getting a lot of concern regarding, do we have a big risk of getting reinfected?
Yes.
And that was feeding these conspiracies.
So a couple of things. As far as I understand it, there's the antigen is the virus, yeah, and then your body makes antibodies to combat the virus. And the first antibodies are the IgMs, they're like the stormtroopers, and the IgGs are the sort of later ones that come later to mop up after stormtroopers have had the initial fight. So I remember it as IgM is immediate, and IgG means G for getting better.
That's right.
Yeah. So, what tests were on your family, Al? Do you know which ones were tested, IgM or IgG?
So my family wasn't tested because they weren't admitted into any healthcare institution. So they were just told to, like the majority of the population, they were told to just isolate at home and see through it. I had the IgM test, the PCR. I think it was a PCR IgM test.
Yeah.
And as I said, it came out negative.
Yeah, but it might have been that Al did have.
I'm just looking here, so I've got it here. So I had so it's IgG negative.
That's the getting better one.
Yes, it's the antibodies.
Yeah, that's the late. That's the longer one, not the one you get first.
But what's interesting is actually where we, so the friend of mine who organised the, thanks, darling, thanks. For those of you who are just listening, I've been having a hair nightmare today. It's every day because I need my roots in. Anyway, there are more important things, I guess. But going back to it, so the friend who organised mine, out of the nearly 40 tests that he had done, only one had come back positive. But yet a lot of the people had believed they had had it.
That's the issue, is that it's the sensitivity levels. One of the things that we discussed earlier on is that as healthcare professionals, we require hepatitis B immunization in order for us to practice. And the whole vaccination process, I remember we went through three shots, each done a month or so apart, and then multiple boosters may be required in order for us to attain the right antibody level that would give us the immunity. At this moment in time, I don't believe we really know what the level is that will give us immunity. And we still don't know how long those antibodies will remain in our system to give us that immunity. So we may find that we may be liable, that we may find ourselves vulnerable for a reinfection a year from now.
Yeah.
So a couple of things. So you obviously then were admitted into intensive care and put onto assisted breathing. Is that right? So
it was placed on CPAP, yes.
And just explain to us what that actually means.
So you have two types of assisted breathing. Well, there's one where the machine breathes for you completely, where you're sedated and you're what's called intubated. And that's basically not a nice experience where it's placed down the back of your throat. And it, to be honest, doesn't give very good outcomes anyway. The alternative is CPAP, which is a mask which is placed over the nose and the mouth, and it's tightly fitted. And its job is to ensure that your airways remain open. So you always have an element of pressure that's being applied to keep the airways open, and then it has a detector in it which then enables it to then determine when you're wanting to breathe in and out, and then it assists you with that. So you have various variations on that as well. So you have a BiPAP, you have continuous positive airway pressure as well. And that's something that I'm sure an anaesthetist will be able to explain in much greater detail.
Yeah. So as I understand it, your lungs are not working efficiently, they're full up with fluid. So your saturations go down, you can't get enough oxygen in, a bit like when you're running, you're just out of breath all the time. First thing is to increase the amount of oxygen you have, because normal air is 20%, so they can put it up to 80%, giving 4 times more oxygen. So that sometimes helps. If that doesn't help, next stage is CPAP, which is pushing the oxygen in. And if that doesn't help, next stage is intubation, where the tube goes down your throat. And they, yeah, is that right?
That's absolutely right. But I think one of the things that the general population may not know is that COVID actually has 3 main effects, 3 main manifestations in the lung. The cytokine storm that we talked about, which then can cause the pneumonia picture. But the effect on those ACE inhibitors that we talked about a little bit earlier on, also responsible for causing restriction in the blood supply that comes to the lungs. So you also get a pulmonary hypertension because of that constriction. And then the third thing that we also mentioned was the effect that it has on the endothelial lining also then promotes clotting. So you then create clots in the lungs and the endothelial lining of the capillaries, which can then be thrown to various parts of the body, and that's how it would affect other organs.
And these are pulmonary emboli, aren't they?
Well, when they're not necessarily, they are emboli, but they're going through the arterial system, through the arterioles, and then can then lodge in any organ. So post-mortem studies that have been performed are showing various organs now with little black necrotic areas because of these clots.
And a couple of so you've obviously had other problems since you got better, if you see what I mean.
Oh yeah. So as soon as when I was discharged, thankfully I didn't have to. And that was the other interesting thing, is that for 4 nights on ITU, and then the next morning I wake up and that's it. No, I was weaned off the CPAP literally over an hour. I was then on high flow oxygen for another hour, 2 hours, and then after that I was self-caring on room air. So the recovery process was relatively quick. I won't say recovery, but the coming out of the danger zone happened quite quickly. And I was discharged that evening.
Wow.
Gosh, that's astonishing, isn't it? So once you talk about this getting over the line, it's almost like there's a tipping point going into this respiratory crisis, and there's a tipping point coming out. It's sort of like children when they get ill very quickly and they come out very quickly. And who was keeping in touch with your family? How were your family informed while all of this was going on?
So when the ambulance whisked me away, I didn't have my phone, I didn't have a bag, I didn't have anything. So I found a bag sitting beside me when I woke up in the middle of the night, and my phone was in it. And thankfully, my sister-in-law is an immunologist at the Royal Free, so she was the point of contact. My wife wasn't feeling too well, as she was going through COVID anyway. So we had the one point of contact, and that was my sister-in-law. So big hi to Nisha at the Free. So thank you so much for everything you did.
Amazing. So you're on ITU the night before, and then the next day you're out home.
Yeah, crazy.
Yeah. Well, we're very glad you're back home, but you've had problems since.
Well, yes. The whole ARDS, and it was almost a septic picture for a short period of time. So as you know, that can cause all sorts of deranged enzyme levels. And so I had, my liver function wasn't great for a month afterwards. I think the prolonged dehydration the illness was also responsible for potentially my 2 kidney stones that were discovered. So I ended up with renal colic. Oh, it was a very, very painful experience. And then the strangest one was an arteritis that I had whilst I was admitted. So for those that don't know what an arteritis is, it's an inflammation of a blood vessel. And it can cause extreme tenderness. And in my case, I had this extreme tenderness in my temples and down the back of my head. And after discharge, because I had my trusty pulse oximeter to monitor my progress and rehabilitation, I was finding that I had this persisting tachycardia. And
High pulse rate.
High pulse rate. High pulse rate. So this high pulse rate has just persisted, and now where are we now? We're now in June, and my heart rate still runs at between 10 and 15 beats per minute more than it did before I fell ill.
What is the number? What's it running at now?
I'm in the low 80s.
And have you been exercising? Can you exercise?
Yeah, so I'm exercising absolutely fine. I'm rowing most mornings, go on long walks to the woods nearby, play with the kids in the garden. But it's just that the heart rate seems to be a lot higher. I had it investigated by one of the cardiologists at Harefield, Dr. Rob Smith, highly recommended, who said that his practice actually is quite busy with people with these unexplained tachycardias. Said it's nothing to worry about, and these things usually normalize over 2 to 3 months after the viral illness.
Yeah. Just before we finish on this particular topic, what would your advice be? My question is, what would your advice be to anyone out there who has not had it? What should they be doing?
If you're in the BAME community, please ensure that you get 15-20 minutes of sun every day, because 90% of your vitamin D comes from sunlight, and no matter how much oral supplementation you take, you'll never be able to get it high enough. So you desperately need the sun, and it probably leads on to the next topic, vitamin D and sunblock, really.
It does. Actually, can we go to that? But I just want to quickly, before we go, I have your views. So I'm saying this because Boris Johnson very clearly, before he experienced COVID, seemed to have one approach towards it. And then after he's experienced it, seemed to have a different approach towards it. And can you see that in yourself? Because there's very definitely a population out there that think it's a bad cold, it's nothing more than that. Those people who are getting sick, they would get sick anyway. Sort of, how's that affected how you're now interacting?
Well, it's very interesting, looking at the color of my skin. Those individuals that say it's nothing more than a common cold and most people will recover from it, if you look at my social circle, I've lost 5 acquaintances.
Really?
So it's been an absolute massacre in my social circle. And yes, I predominantly have friends and family from the South Asian continent by lineage, and they're the ones that have been hit worse. 5 deaths.
Can you just explain? Sorry to disturb you, but who were they? I mean, if you're not giving details, were they men, women, your age?
Men, women. Some were elderly, so 3 of them were in their 70s, but fit and well in their 70s. Another was 33 years old, and another one in their 50s. So, but taken away from us prematurely.
Yeah. So
being in your 70s is young, isn't it, Adrian?
Yeah, very young, very young. So I mean, that's fascinating. So how can we protect ourselves? So I've just looked at my thing, got my glasses on because I'm old, and it doesn't. So it has a lot of things in it, but it doesn't seem to have magnesium, and it doesn't seem to have vitamin C.
Right. So vitamin C is a great one to take in high doses. If you have a viral infection, usually the common cold or the flu, it's been known to decrease the time and duration of the bout of illness, so you recover that little bit quicker. Vitamin D, we're talking about as potentially reducing the level of the cytokine storm that you may get in any viral pneumonia. But vitamin D is so important anyway for reduction in the risk of peripheral vascular disease, atherosclerosis, and many types of cancer as well. So you're at way lower risk of even getting breast cancer if you have a normal vitamin D. So that's the most important thing.
What about magnesium?
Magnesium's great to help with the absorption. I would say though for viruses, zinc is more important. So that's part of my regime. So
Magnesium's good for sleep.
Magnesium.
So what's your regime then, Sash? I'm just writing this down. So zinc as well.
So I take zinc. I take a lot of turmeric because that's a beautiful Ayurvedic anti-inflammatory. So that's a really good one for me. And then vitamin D, I take mine as a sublingual spray.
Yeah.
And I'm having, I think it's 3,000. I alternate between 3,000 and 6,000 units per day.
Okay. Now you mentioned you can't get enough vitamin D just by supplements. So why is that? And what role do sunblocks play? And avoiding sun.
Okay, so a study performed in Boston showed that at the end of summer, if you're Black Afro-Caribbean, you are at 82% risk of still having insufficient vitamin D levels. That if you're Caucasian, your risk is, I think it was half of that. So even after summer, a vast number of the population will still never even attain adequate vitamin D levels, and these continue to drop off during winter. As we discussed a little bit earlier on, because of the tilt of the angle of the Earth and the thicker ozone levels, a study performed by the same team also demonstrated that no matter how much sun you get in Boston throughout the whole of the winter, it's inadequate to actually help you make any vitamin D whatsoever. So we're stuffed, really. There's no way out of it.
So what should we? So Al and Sash, you've been advising your patients to take sunblocks. Have you changed?
Oh, for me, my practice will change significantly now, where I will tell every single patient that they are not to apply sunblock at all for the first 15 minutes of any sun exposure.
And can you get enough from your face, or do you have to expose your body?
So the greater the surface area of exposure, the more vitamin D you will make. So if you can imagine, we're only on holiday 4 weeks if we're lucky a year. So the rest of the time we're clothed, usually on a commute. So the only exposed areas are our hands and our face. And it's for that reason I will now be telling each one of my patients that they are not to apply any sunblock whatsoever unless they are at high risk of burning. If they're on training.
Yeah, exposing yourself on a commute is not recommended, is it?
that depends. Depends how long the coat is.
yeah. Anyway, so Al, so we were going to talk a little bit about moving on to your practice, the different demographics. I know you have a lot of Indian patients coming to see you in the Revere Clinic, Sash. Do you think we should do that now, Al, or do you think we should?
Yeah, I do, because I think it's a niche thing, and it's a specialist thing that Sash does. Sash does, and I think, like I say, when I met you, Sash, probably 12, 13 years ago, you were just at the beginning of setting up Revere Clinics. And so now you're predominantly based in Harley Street. And why is it, okay, without stating the bleeding obvious, you're Indian, why is it, do you think, you have attracted this patient base? Is it because you do things differently? Is it because of the word? What is it?
I've been very, very lucky in that my first few Indian patients that came to me were from a very, very eminent family who are in healthcare. And they run a massive chain of hospitals in India. And as the promoters, they themselves were telling their whole social circle that they wouldn't, despite employing 7,000 odd doctors themselves, that I was their go-to person. So when you have that kind of endorsement, you then find it very, very easy and you find, well, and these patients just kept coming, and it was just from this one family. And that opened the doors up for me in Bollywood, so the whole of the Indian film fraternity out of Mumbai, and then Tollywood, which is based out of Hyderabad. And a lot of my friends are out there. I went out there to celebrate my 40th, and I'm very, very fortunate. That's all I can say, to be the go-to person. You know, I've done a similar interview for an Indian talk show host on her Insta Live just recently, where she had 1.1 million followers, and I'm interviewed regularly by the national press out there. So it's a very, very fortunate position to be in, and I'm honoured and humbled to be the Indian doctor outside of India that a lot of Indians want to go to.
Oh. And Tollywood, why is it called Tollywood?
I think T is for Telugu, which is the language in South India.
Oh,
That's a great question. I've never been asked that.
oh.
I guess it can't be called Hollywood, even though it's from Hyderabad. Are you not tempted to go to set up out? I know you're saying about having a practicing license, but are you not tempted to go out to India and set up?
I have been approached many times to expand the Revere group out there, but the problem is that due to the nature of the client base, they only want me.
Yeah.
So that's, and for all the practitioners out there watching, that will always be one of the limitations to growing an aesthetic practice, is that, no matter how big the team gets, the key limitation would always be the fact that we've only got one set of hands.
Yeah, I mean, that is the same for surgeons. It's the same for you, Al. It's the same for everyone. And yeah, that is an interesting point. Now, you were mentioning earlier, Sach, I was very interested that you've got a lot of Chinese clients as well. And could you tell us some of the differences that the different Chinese, Indian-based and European-based, what are the differences between the treatments they like and the looks they would like?
I think the way in my practice in general, whenever anybody comes in for a consultation, they all seem to want to look Mediterranean. And that is the ideal in terms of, if I take all of my Indian contingent and the Chinese contingent, they want to look slightly more Western, whereas anybody else from all the Caucasians in the UK particularly want to look more Mediterranean. They want to look more Eastern. And that sweet spot is in the Mediterranean somewhere. So, Alison, Italian, Greek, what would you generally prefer?
Italian, probably.
Italian. So in terms of the ideals, that they have stronger features. If we look at the Chinese and the Indians, they want to be fairer.
Yep.
They want to have a more heart-like facial appearance. They want to lengthen it because they generally feel that their faces are rounder. So in the practice, we find ourselves literally trying to turn that round shape into a more inverted triangle. So that will involve enhancement of the lateral cheeks, more so than the frontal cheeks, and then a thin face wherever, and that could be done with a deoxycholate injection to reduce some of the fullness, or mesoteric Botox, and then there'll be chin enhancement as well with volumizers and augmentation wherever required.
So dissolve the fat where you don't want it, add volume where you do want it, and reduce the muscles.
That's right.
Yeah,
and the chin.
Yeah, and the chin. And in the UK, what's the look people are looking for in the UK?
Everybody wants to look everyone still wants to look like the Kardashians, and I'm spending most of my time trying to steer them away from that, because it's currently a fad. I don't see it lasting more than another 2-3 years until people get bored of those big lips and those big cheeks. They themselves don't know what they want from one day to the next. So they're forever inflating and deflating their own faces. So
I think that's probably your younger group. I would say. Do you think? I'm just thinking of, I don't think, do people in their 40s come in and say that they want to particularly look like someone? I mean, I think people look at people like Amanda Holden and admire the way that she looks and things like that. But I think as we get older, we're just trying to hang on to more of what we had.
I think the most aspirational work that I've seen was Demi Moore up until about 3-4 years ago. A very, very subtle transformation program that she went through, and she looked absolutely amazing. I don't know who her surgeon was. I wish I knew who her surgeon was, because I would go and give them a big pat on the back, because it's not often that you see extremely good work in the public domain, because, as you know, the press likes to ridicule celebrities when they come out having identifiable work done. And
do you think she's had surgery, Sash?
I think she's had significant amounts of surgery, actually. I think it's been combined very well with some non-surgical work, clearly improving her skin, improving the tautness of the skin. So she's had some skin tightening done alongside a possible mini lift. I think she's had her eyes done as well.
Yeah,
she's 57.
Yeah,
she's 57.
Yeah. So what other? Let's talk about. Can we talk about some of the celebs? So what do you guys? You've got an eye for these things. What do you think people have had done?
I think people, like I say, sort of Amanda Holden. I'm only saying that because I think we might be similar age. I think people are having mini lifts and procedures before we would historically have thought someone might need one. So I think there's that. But I think there's a lot of, like I say to my patients, patients will sort of say, why do they look so good? But equally, they will be having non-surgical, they'll be having device treatments, old therapy, radio frequency, lasers, and all of that. It's to look that good takes a lot of work.
Yeah. So someone like Liz Hurley looks great. Yeah. So
she will have had a nip or tuck though, because she's in her mid-50s. You just don't, you just don't get to that point unless you're really investing time in it. The only thing I always say to patients is someone like Keira Knightley, who's incredibly class 3, she probably will age reasonably well non-surgically, because she'll flatten in the malar, so we'll be able to volumize her, but everything won't fall off her jawline because she's got such a strong jawline. So I think some people will age better non-surgically, but there ultimately comes a time when you're postmenopausal, when non-surgery, the benefits of it become more subtle.
And that's when you need to take up boxing, because that's the one way to ensure that you don't get the atrophy in the skull. So I really, really do recommend it. If you look at retired male boxers, for example, if you look at the George Foremans, the Mike Tysons, the constant battering that they've had to their skulls has basically resulted in significant regeneration of their bony structures. So they're not experiencing the same atrophy that the rest of the population would. So that my top tip is that if you feel that if you're aging, just go a few rounds with Mike Tyson.
Yeah, you're the second person in 2 days who's mentioned boxing. And I don't know, we interviewed Norman Waterhouse yesterday, and he sent me a video later, Al, of him boxing. And it's pretty impressive.
I'm going to be Adrian's boxing promoter. You can sponsor his shorts, Satch, and we're going to put him in a white collar fight at the end of whenever we all come back together. We've got to choose who he's going to go up against. So
a white collar fight is when you train and then you have a sort of fight night. And I'm not going to fight Norman. He looked quite scary.
But it's a 12-week strict training program, and then you sell all the tickets for charity, and it's just a big charity event where we watch someone.
I saw the equivalent of this on Billions, and no, I'm not queuing up to do this at all. particularly with Adrian. I've got to thank Adrian for being the one person who really helped me in the early stages of my career. I was one of the first people to come on the Cosmetic courses training program. So that's I can't be seen punching Adrian ever.
No, you were our star pupil. I think you've done so well. So guys, that's brilliant. Real great overview. I think you know, I definitely would like to know the supplements you'd recommend, Sash, because I'm just going to put them on my desk and every morning have them, and I'm going to encourage my family and friends to take them. So definitely we'll put those in the show notes. And you know, really pleased you're feeling better and looking so good, and you've got over, you know, difficult time.
And so, Sach, when are you thinking of going? What's the plans next? When can you see yourself going back to work? With the current muddled guidance.
It's that's the problem. It's very, very muddled guidance at the moment. Whilst our professional body, BCAM, have given us clearance since the 12th of May, it's impossible for us to open the clinic because none of the staff are permitted to take public transport because it's still deemed to be a risk. Until all our ducks are lined up, where, you know, I know I can go back to work. I know fingers crossed we get clearance when the staff can take public transport to come into work. For those practices, you know, where all the staff are driving in, that's not an issue. But in London particularly, it's extremely difficult for both the patients and the staff to come in without public transport. And nobody's really looking to come in. Nobody's looking to drive in now because our wonderful mayor has increased the congestion charge now significantly. So it's now, I don't know, is it 15 odd pounds? I can't remember.
I think it's quite a lot, unless you've got an electric car.
I think no. Time to get one.
Time to get an electric car. So Al, anything else you'd like to add? It's been absolutely brilliant, Sash. Really enjoyed our conversation.
It's been lovely. It's been too long, and I think we'll all be really pleased to get together when we come out of this. And I'm so glad, Sach, you're better. And thank you for sharing your story. I think it's been brilliant.
Yeah,
thank you so much.
Really appreciate your time, guys, and hope to see you soon in person in London or at a conference. So thanks, guys.
Bye, darling.
Bye.